Assalamu alaikum, my dear students. Today we are going to talk about a very important subject in general surgery, and that is the thyroid gland. This gland not only manifests its symptoms and its, whatever it does, not only at one organ, but in multi organs, and it controls the many functions of the body. So when it is working normally, it is very friendly, but when it goes against, that is, the pathology is developed, then there is a problem in the body and multifactorial problem. Now let's start with just to brush up your memory, anatomy and physiology. We are going to talk about it now. As you all know, there are two lobes, right and left, both lobes joined by isthmus in between, and it gives like a butterfly shape. In some patients, there is a remnant of thyroglossal duct, which is known as pyramidal lobe. As you can see, it is in the middle, right? And then pyramidal lobe is attached to hyoid bone by cartilage by fibers called levator glandulae thyroid. So this is very important because sometime what happened that it is a thyroglossal cyst which we have to remove, and then we have to remove this hyoid bone as well. Okay. And as you all know that the thyroid develops from the 1/3 and 2/3 junction. There is a foramen cecum. It develops from there and then it descends downward. And along this track, it can be caught anywhere and gives the different pathologies like aberrant thyroid, like maybe fistula and maybe thyroglossal cyst. So we have to know this embryology and its descent down to the neck. Sometimes it doesn't stop in the neck; it goes down behind the sternum, and which we call the retrosternal goiter. All right. There are a few ligaments and fascias which are important, like suspensory ligament of Berry. These are the condensed connective tissue which binds the gland firmly to the cricoid cartilage and upper tracheal rings. Then there is a pretracheal fascia, which is a part of deep cervical fascia that splits into two and it invests the gland. So the gland lies inside. So if you have to remove, the gland, you have to remove the fascia as well. It's one important thing is ligament of Berry and pretracheal fascias. They are responsible for the movement of gland with the deglutations. Whenever you swallow, the gland will move up. This is a very important sign when we will go forward that this will differentiate the thyroid gland from thyroid goiter from the thyroglossal cyst. Now, this arterial supply of the thyroid, very important. It has got, as you know, that superior pole and inferior pole. So superior thyroid artery, which comes from the external carotid, it supplies the superior pole, and then there is a inferior thyroid artery from the thyrocervical trunk, which comes from the subclavian. This supplies the inferior pole, right? Sometime in 3% of patients, the thyroid ima artery is there, which comes directly from the aorta, and it also supplies, so we have to tie it if it is present there. Then the nerves in relation of the thyroid, as you can see that these nerves are very important, especially the recurrent laryngeal nerve, because if you cut it, then there is a problem with the movement of the vocal cords. So you have to take care of it. You can see the relations of this nerve, and this is the view from where you can also see from posteriorly the superior parathyroid glands and the inferior parathyroid glands. They are 4 in number. So you have to know that, because if you remove the thyroid in total thyroidectomy, you have to take care of these parathyroid glands because you don't want to remove them. Otherwise, there will be a problem with the calcium metabolism. All right. So if you remove them by mistake, you have to transplant them, and at the place where you can access them, like in sternocleidomastoid, and then you put a black silk, something just for a reminder that it is there. Okay. Then this is the feedback mechanism of the thyroid hormone. And as you can see from the hypothalamus, this is the thyroid releasing hormone is there, which acts on the anterior pituitary, and then it make it release the thyroid stimulating TSH, and it will go on the thyroid and causes the release of T4, T3, which will increase the metabolism. And then there is a negative feedback mechanism. So this chart is very important, right? Just see, from the hypothalamus, TRH is releasing, thyroid releasing hormone, and then it acts on the anti-pituitary and so on. Now, the thyroid function test. Basics. Serum T3, you have to measure it. Serum T4, serum TSH. Usually we go for the FT3, FT4, which is a free T3 and T4, which are more effective and they work on the cell. Then there are the thyroid antibody levels. In these patients, we do these as well. Then there is a serum thyroglobulin for if you are suspecting some tumor. So we know the baseline, and then after removing, we know the level, and then we will monitor it. Whether it's increasing, that means the recurrence is there. And the thyroid scintigraphy and thyroid imaging. These are the important tests which we do in the thyroid patients. Now, just remember a scenario that these are the charts in front of you. As a doctor, you will get the different laboratory tests, and you have to know how to interpret them. I know it's too early for you, but I'm just giving you the insight so that you know how it works. For example, just see that thyroid stimulating hormone. This is just like a manager, always remember. It is released from the pituitary, and it works on the T3 and T4, and it causes them to do the functions. If TSH, thyroid stimulating hormone, is low, right, then because of the negative feedback mechanism, that means that T3 and T4 are increased. It's vice versa. And if TSH is high, T3, T4 are low. It acts as a manager, and it monitors constantly the level of T3, T4 in the blood, right? And if it's everything is normal going, its level will be normal, T3, T4 will be normal, so nothing doing. But if, for example, T3, T4 are low, right, then this TSH will be increased. That means this manager has to work more, and it will push the thyroid gland to increase more T3, T4, and T4. And if they cannot do it, so what the gland will do? It will increase its size. And so slowly and gradually you will have a increased thyroid in front of your neck, which we call the goiter. Okay? And if, for example, the T3 and T4 are increased, as in thyrotoxicosis, then this manager will be suppressed, this TSH, and it will be low, and vice versa. So you have to understand. Now we'll go through this chart quickly, right? TSH high, okay, if in these conditions, then and T3, T4 are normal, right? You can see the normal levels. Interpretation is the hypothyroidism, okay? Manager more active, TSH more active, T3, T4 either normal, that means the hypothyroidism is there, but it's subclinical at the moment. It is not detectable. And in another scenario, if it is high and the T3, T4 are low, that means it is a chronic thyroiditis or post-thyroidectomy. If you have removed the thyroid, then it will develop the hypothyroidism. Okay? So in hypothyroidism, TSH increase, T3, T4 are low. Then again, TSH low. If it is high or normal, T3, T4, that means the subclinical hyperthyroidism, or thyrotoxic patient is taking the thyroxine as an ingestion tablets. If the TSH is low and T3, T4 they are high, that means that either there is a primary hyperthyroidism, that is the gland is working more, or there is a decurvance thyroiditis, right? So you have to know these. And if the TSH is low, another, or if maybe normal at times, and T3 is high and T4 is normal, that means the T3 thyrotoxicosis. Because the T3 is high, T4 is not high. Okay? So these are the interpretations. Not difficult. Once you go through it, you will know how to interpret. But you have to remember one thing. TSH increase, T3, T4 are low. If T3, T4 are increased, TSH is low. It's vice versa. Now, congenital anomalies of the thyroid. It may be ectopic, lingual, thyroglossal cyst. There may be fistula, thyroglossal fistula, lateral aberrant thyroid. There's a thyroid which is trapped in the line of descent on the both sides, agenesis or dysharmogenesis. These are the congenital anomalies of the thyroid. Just see the ectopic thyroid, position of the lingual thyroid. Just see, there's a left tonsil, uvula is there, it is behind it. Now the THYROGLOSSAL cyst, very important. They will ask you an exam, clinically how will you differentiate. You tell them that if you will ask the patient to move this deglutition or the swelling, and if the thyroid moves up, that means it is a gland, and if it does not move, that it may be the THYROGLOSSAL cyst. But if you protrude the tongue, okay, and if the swelling moves, that means that this is a THYROGLOSSAL cyst. You know why? Because as we just saw previously in the development, that the thyroid developed from the foramen cecum. So it is the attachment. So when you protrude the tongue, and if it is a THYROGLOSSAL cyst, it will move. It's a very important point which you have to understand, right? Congenital, and there is a degeneration of the part of the tract causing cystic swelling. It's a tubulodermoid type of cyst. That is, the pseudostratified columnar cells are lining it. Possible site for THYROGLOSSAL cyst, it may be subhyoid, for most commonest site, right? Then the thyroid cartilage, second commonest, suprahyoid, and beneath the foramen cecum, right? And floor of the mouth. Just see, THYROGLOSSAL cyst. You can see the swelling in the midline. Right? Just see the cyst. Swelling move with deglutition as well as with protrusion of the tongue. And malignancy's chances are very rare. Papillary carcinoma, if it develops, it's only 1%. Investigation are the same, which we have gone through, that the DFNAC, ultrasonography, or the radioisotope scanning, standard for the thyroid. Treatment, cyst tongue operation. At this level, I shouldn't mention it, but just to know, because it's very common, and they might ask you in the final year, X-ray of the cyst and also full track of the foramen cecum is done, along with the removal of central part of the hyoid bone. This is very important. They ask you which bone will you remove. So you will say, because the attachment there, central part of the hyoid bone, you have to remove as the track passes through it. Okay. So cyst trunk operation. Clinical examination of the thyroid swelling will go just quickly, because this is what you have to do in third year and fourth year. Goiter swelling of, what is goiter? It is a swelling of the neck resulting from the thyroid enlargement. We call it goiter. And it can be either patient euthyroid, that is a normal thyroid levels functionally, or it may be less functioning hypothyroidism or more functioning hyperthyroidism. Right? So euthyroid is a normal functioning gland. Hypo, if it is working less, producing less T3T4, or hyper if it is producing more T3T4. Alright? What will happen with the TSH? You all know it will be reverse. In hyper, TSH will be low, and hypo, TSH will be high. And euthyroid, TSH will be normal, T3 normal, T4 normal. Causes, more common in women. It may be due to physiological, maybe due to iodine deficiency. Therefore, nowadays they've got the salt which is iodized. Okay. And physiological, at the time of puberty, when there is a stress and the body is developing, and there is a lot of need of this hormone, then it has to work more, and it increases in size. But afterward, when this emergency is over, it regresses. Autoimmune thyroid conditions as well causes the enlargement. Radiotherapy, if you do radiotherapy due to any reason, radioactivity, unusual dietary habits, and medications. Now the classification of the goiter. How will classify? Everything you have to classify. Why classification? It will make the thing simple to remember as well, and to diagnose patient, and to treat them. So it might be either there is a non-toxic or toxic. Okay, so first of all, whether this is a toxic condition or non-toxic. And there is a neoplasm, there may be malignancy, it may be due to inflammatory, and rarely due to infection or amyloidosis or cyst or abscess, there is also a goiter. But the usual conditions are Other is inflammatory like riddles, Hashimoto's, decurenins, and neoplasm like papillary, follicular, medullary, anaplastic. Toxic or non-toxic, both can be diffuse. Diffuse means they will be same whole enlargement of the gland, not a part of it, whole. It will be similar, or it may be multinodular in both types, different nodules, or it may be a single nodule, or it may be recurrent, right? So what you have to do is you have to see first whether the patient is non-toxic or toxic. Toxic means T3, T4 are enlarged. Okay, they are hyperfunctioning gland. So there may be a single nodule, there may be multiple nodules in different stages of development. It may be diffuse, plain, or they will be recurrent. All right. So it may be toxic, it may be non-toxic. Maybe neoplasm, like I told you, papillary follicle, they are the most common, then medullary, then anaplastic, then inflammatory, and then rare condition infection, cyst, sepsis. Presenting complaint, how the patient says that longer standing swelling, and there is a benign condition, short duration with rapid growth, which we call malignant condition. Okay, if it's slow growing for a long time, usually it is a benign, and if in short duration it is increasing in size, suspicious of malignancy. Sudden increase in size with pain, that means that there is a hemorrhage. This is a question they ask you in Viva, that patient has got longer standing goiter, and what happens suddenly in one night, there is a severe pain. What may be the cause? Then you have to tell them that it might be hemorrhage, bleeding. Rate of growth, slow growing, rapid growing. Then it might cause apart from the swelling, it might cause the pressure, because there is a gland, and then there is a trachea in front, and behind the trachea there is the esophagus. So it might cause, if it is large, substantial amount, it will cause the dyspnea, difficulty in breathing, right? Usually it occurs in anaplastic, which is very hard, and retrosternal, it causes the pressure. Long-standing multinodular goiter, if it is very large, and secondary thyrotoxicosis, right? That means there is an increased T3, T4, not because of the pathology in the gland itself, but pathology somewhere else. So therefore it is called secondary, not primary. Then it may present as hoarseness of voice, like in malignancy when it involves the vocal cords or the recurrent laryngeal nerve. Okay. Toxic features of hyperthyroidism. Right. CNS symptoms, there are tremors. If you stretch your hands, if the patient stretches hand, it will be tremor. If you put a plain paper over it, you can clearly see its movement. Then excessive sweating in the palms. Patient cannot tolerate the heat. He will prefer that there should be always air conditioned or cold weather. Preference for the cold weather. Excitability, irritability. Patient will be very irritable, angry, right? Then there are serious symptoms in which there is palpitations, right? Patient can listen his or her own heart sounds, and there is an increased rapid movement of the heart, and precordial chest pain sometimes, and dyspnea on exertion, just mimicking the angina. History taking, what you should ask if such kind of patient comes to you. You have to ask what is the onset, when it starts, what is the duration, how it progresses, slowly, rapidly, what is the time you're talking about, in months or years, or whether there is a pain or not. Then you look for the local effect. If there is a dyspnea, difficulty in breathing, dysphagia, because behind the trachea there is a esophagus. So sometimes it also causes so much pressure that there is difficulty in swallowing as well. Then hoarseness of voice changes because of the involvement of the recurrent laryngeal nerve and then the vocal cord, and pain. Okay. Toxicity, and then hypothyroidism, lethargy. Patient said that in hypothyroidism, well, I will do this work, not now, afterward, later on, he will try to delay. Deposition of fat, you can see in the face and in the arms as well, and deep husky voice, and intolerance to cold. Patient cannot tolerate the cold in hypo. In hyper, patient cannot tolerate the heat. So you have to remember that, because the metabolism increased, BMR. On examination, what you will see? Inspection. As you all know, that is the thyroid is in front of the neck in the midline, on both sides, like a butterfly. So, in front of the neck, extending horizontally from one sternum-mastoid to another, and vertically from suprasternal notch to the thyroid cartilage. So, this is the anatomical landmarks. Okay. Size and shape: surface smooth in adenoma, puberty, goiter, and Graves' disease, irregular in carcinoma, and in nodular it will also bumpy, multinodular goiters. Border is usually round, and the thyroid glands, it moves with deglutation, and swelling which moves with deglutation is thyroid swelling, subhyoid bursitis, pretracheal and prelaryngeal lymph nodes, thyroglossal cyst, and laryngocele. Restricted in malignancy, it does not move retrosternal goiter and large goiter. Now, protrusion of tongue, the gland will move in thyroglossal cyst. Why? Because I told you that it is attached with the hyoid bone, hyoid bone, and then from the foramen cecum it develops. Palpation, local temperature, you will see size. It's all for all the swelling. Local temperature, size, side, shape, surface, borders. Very large nodular surfaces we call in thyroid bosilated surface. That is a bumpy surface, bumpy, bosilated. Consistency: Graves' disease and colloid, it is soft. Adenoma and multinodular goiter, it is firm and hard like a bone in carcinoma and calcification of the multinodular goiter. It will be hard like a bone, firm like a tip of your nose, right? And soft like lips. Confirm the movement, okay? You have to ask them that please swallow the water, give them a glass of water and ask them to take a sip. Intrinsic mobility of the gland, locally it is moving or not. Investigations, you have to ask them for the simple blood test, because eventually when you have to go for a operation, you need them because of the anesthesia as well, and you have to know what is the hemoglobin. So you have to go for the complete blood picture, urea, kidney functions, liver functions. You have to know the X-ray chest, ultrasound scan, final aspiration, cytology. You just put a small needle inside and you take aspirate. Then you don't take out the needle outside the skin. You just move it inside 6 times at least, and then you aspirate in different position. Then you take it out and then you push it over the slides and you air dry them, and then you see it and then send to the laboratory as well to see what kind of cells are there. This is FNAC. Then radioactive iodine scan. Treatment, this may involve one or several of the following. Either there may be surgery, in some cases you have to give them radioactive iodine, or antithyroid medications, or levothyroxine tablets, right? So these are the different ways how we treat the thyroid patients. Goiter, we know the definition. It may be diffuse, I told you. Whole gland enlarges together, right? Or it may be multinodular, maybe a single discrete nodule like a solitary, right? Or it may be retrosternal goiter. Prevention: if there is a puberty goiter, right, at the age of 14, 15, then you give 0.1 milligram thyroxine. If iodine deficiency, you use iodine salt, seafoods, milk, eggs, etc. And goitogens, avoid cabbages and drugs, because it causes the enlargement of the thyroid gland. Types, told you before: toxic thyroid nodule, non-toxic thyroid nodule, based on the radioisotope study. This is very important. What happened that we give the radioactive iodine and then we see through the gamma cameras. If it is a hot nodule, right? In hot nodule, what happened that it is taking the more of the dye. Okay, it is taking the more of the dye. But in this case, what happened that the chances of malignancy are very few. Okay, maybe 3 to 4%. In hot nodule, then there is a warm nodule. It's a normal function nodule and taking the normal amount of the isotope. And in this also the malignancy chances are less, 5%. Okay. In cold nodule, that is, it is not taking the isotope. This is, in fact, it is a dead tissue there. And in this, there is a chances of malignancy around 15%. So we have to take these out. If there is a cold nodule, then we go for surgery without waiting. Let's see, this is a cold nodule. Not taking anything, dye. It's taking dye, this is not taking dye. Hot nodule, only one part is taking excess amount of the dye. Radioactive iodine, sorry. Okay. Thyrotoxicosis or hyperthyroidism. Excess production of the thyroid hormone by the thyroid gland itself is known as hyperthyroidism. And if excess thyroid hormone is there in the body due to any other cause, right, that is not producing from the thyroid gland, then you call it thyrotoxicosis. Okay. Hyperthyroidism may be of two types. I told you, primary or secondary. Primary means when the pathology is within the thyroid gland. Secondary, when the thyroid gland is stimulated by excessive thyroid hormone in circulation. Types of thyrotoxicosis. Diffuse toxic goiter. This is a plain, usually in young girls, and it is known as Graves' disease. Okay, Best-Dose disease as well. Then there is a toxic multinodular goiter. That is, it is not smooth. There are different stages of nodules there, like plumber's disease. Or there may be a single nodule, toxic nodule, or there may be other causes like thyrotoxicosis, factitia, and Jod-Besdow thyrotoxicosis. Autoimmune like recurrence thyroiditis, right? The other one. You see this young woman, how her eyes are protruding. You can see the sclera, the white thing all around. You see below as well, right? White all around. Usually you can't see this lower portion. Okay. Etiology, autoimmune disorder, most common, and young people, and due to increased level of the TSH receptors in the blood, thyroid stimulating immunoglobulin TSI and long-acting thyroid stimulators causes pathological changes in the thyroid. Also associated with other autoimmune diseases like vitiligo. Familial and in twins, identical twins, they have seen it. And exophthalmos producing substance responsible for ophthalmopathy because there is a pathology in the eyes as well. You can see it's a protruding, seen in Graves' disease. Clinical feature, it is 8 times more common if females occur at any age group. Now, this is primary versus secondary thyroid. It's very important for the physicians as well. Just see, age and sign. Primary, that is the problem with the thyroid gland itself. Secondary, outside the problem is outside the thyroid gland, maybe in the pituitary or somewhere else. Primary, young patients. Secondary, older patients. Here, this primary appears simultaneously for the short time, and long duration of swelling and short duration of signs in the case of secondary thyrotoxicosis. Consistency soft in primary, hard in nodular in secondary. CNS is the predominant system which is involved in primary, and in secondary CVS, that is a cardiac involvement. So sometimes patient only present you with the cardiac problem, and when you investigate, you come to the conclusion that this is secondary type of thyrotoxicosis. So you have to be vigilant. Eye signs common in secondary, they are rare. Pretrival myxedema 1 to 2% in primary, never seen in the secondary. Proximal myopathy 5% in the primary, never seen in the secondary. That is muscle weakness. Malignant exophthalmos can be seen in primary, never seen in secondary. In auscultation, bruit is common. When you listen to the carotid, you can listen a sound like whoosh, whoosh, like this sound, right? And bruit is very uncommon. Why bruit is present in primary? Because the hypercirculation, hyperdynamic circulation. Okay. Symptoms. GI symptoms, very important thing. Thyrotoxicosis, weight loss. There is weight loss in spite of increased appetite. Patient is eating a lot, significantly increase in quantity, but he is reducing his weight. losing his weight, and there's a diarrhea, right? And cardiovascular system, in which there's a palpitation, shortness of breath, exertion, angina, cardiac irregularities, and cardiac failure in elderly. So the cardiologist might send it to you, refer it to you. CNS symptoms and fatigue and muscle weakness, tremors, insomnia, agitation, exaggerated reflux, and skeletal system symptoms increased in linear growth in children. Genital urinary symptoms, oligo or amenorrhea, very important for the females, and occasionally urinary frequency, right? And there may be a hair loss, pruritus, itching, and palmar erythema, very important. You can see the sign. The diagnosis is written on the hand. Signs, eye signs, Stillwell signs, absence of normal blinking, right? Von Graffi sign is inability of the upper eyelid to keep pace with the eyeball when it looks down to follow the examiner's finger. Then there is a Joffre's signs, absence of wrinkling on forehead when patient looks up. Usually what happens when we look up, there is a wrinkling on our forehead. In these patients, because the eyeball is already outside, so there is no wrinkling on the forehead. Then Merobius sign, lack of convergence of the eyeball. We'll see the photographs. You see, Silvic sign, Joffrey sign, spleen, Merobius sign, no convergence, on Graffi sign, right? Exophthalmos, it is the proptosis of the eye, that is, the eyes are protruding outside. Sclera can be seen clearly below the limbus of the eye. I told you before. Clinical feature of thyrotoxicosis. Myopathy. Weakness of proximal muscles occurs. Weakness is more when contract isometrically, either while getting down steps or lifting a full bucket. Okay, when coming down the stairs, there is the weakness which is more, it enhances. And in severe forms, it resembles myasthenia gravis. Now, pretable myxedema. Usually it is bilateral, thickened, dry skin, and associated with exophthalmos. You see, you will not forget it. Thyrotoxicosis may be treated by the following treatment: antithyroid drugs, radioiodine therapy, and surgery. These are three modalities which we use it. Antithyroid drugs prevent release of hormones like logosiodine in previous days. Nowadays, we are using to prevent the production of thyroxine, right? The methimazole, carbimazole, and propylthiouracil. Very important used in pregnancy. Okay, so this is MCQ. Radioiodine destroy thyroid cells and reduce mass of thyroid tissues, where we give primary thyrotoxicosis and then autoimmune toxic nodule or recurrent thyrotoxicosis. Now this is thyroid, inflammation of the thyroid. Hashimoto's thyroiditis, just go through quickly. First describe Hashimoto's as stroma lymphomatosa, that is transformation of thyroid tissue by the lymphoid tissues. Genetic, very important for the MCQs, HLA B8, HLA DR3, and DR5. These are associated with, in this case, genetically. More common in women, male to female ratio 1:10, near menopause, 30 to 50, this is the age group. It's an autoimmune disease. Just see, thyroglobulin 60%, thyroid peroxidase 95%, TPO, and TSH receptor 60%. So if you detect this TPO, so it is that it means that it may be Hashimoto's thyroiditis. Pathology, follicles are lined by Huttel's or Ashkenazi cells. These are very important. It's MCQ. They will ask you, they will just give a scenario that Huttel cells are present in a specimen, what it can be. So we will go for the Hashimoto's. Laboratory findings, you know that what will happen. Presence of thyroid autoantibody, particularly TPO, thyroid peroxidase, antibodies. Decurrence thyroiditis. This is viral thyroiditis or granulomatous thyroiditis. Peak incidence 30 to 50 years, more common in women, usually follows upper respiratory tract infection. A viral etiology has been proposed, a strong association with HLA-B35. So you have to remember this, right? HLA-B35. Clinical features: painful enlarged thyroid, malaise symptoms of upper respiratory tract infection preceded the thyroid-related features for several weeks. That means before few weeks there is all symptoms of upper respiratory tract, and after that will follow by the thyroid-specific symptoms. The patient typically complains of sore throat and small, exquisitely tender goiter. If you put your hand, it will be tender. This is a good sign. Then there is a riddle thyroiditis, a rare variant of thyroiditis characterized by replacement of all or part of the thyroid by the fibrous tissue. Now hypothyroidism, decrease in T3 and T4 and increase in TSH. It may be a primary disease of the thyroid gland, secondary disease of the pituitary gland, or tertiary disease of the hypothalamus. Therefore, I told you that you have to refer back to your previous chart. Signs and symptoms. Cold intolerance. Patient in hypo cannot tolerate cold. In hyper, it cannot tolerate the heat. Preference of warmth, mental lethargy. Everything is slowed down because the basal metabolic rate is slowed down. It is dependent on the thyroid hormone. Then decreased appetite. In hypothyroidism, it was increased appetite, weight gain, right? Despite of the decreased appetite. Just remember this. Menorrhagia and constipation. Signs: decreased sweating. In hyper, it was increased sweating, palmar sweating. Here, this is a decreased sweating, dry skin, bradycardia, and bradykinesia. And this is very important. The delayed relaxation of ankle reflex. Most important sign. There will be a slow ankle reflex. Okay? Cretinism. This is the hypothyroidism, congenital hypothyroidism, and in children occurs in 1:4,000 live birth. Causes why? Because of thyroid dysgenesis, mother on antithyroid drugs, or dietary deficiency. Clinical features: hypotonia, prolonged jaundice, enlarged tongue, umbilical hernia, coarse or thick skin, and hoarse cry. Treatment: L-thyroxine once a day, morning orally. It's very important because if you detect it early, and that is at the time of birth, in within few days, then you can prevent the mental retardation in these child. They will be normal. It's very, very important to know this. You see, congenital hypothyroidism. Myxedema in adults, there is a hypothyroidism. Clinical feature: all signs and symptoms of hypothyroidism. Supraclavicular puffiness, malar flesh, that is redness at the cheek, yellow tinge to the skin. Myxedema, neglecting patient will go into myxedema coma. All features of myxedema plus hypothermia, that is, patient will be cold, temperature will be low, and mental deterioration. Thyroid neoplasm. We divide them into malignant and benign and malignant. Okay, then that can be benign follicular adenoma, and in malignant there will be primary or secondary. In secondary, metastasis from other organs, or there may be local infiltration. Primary, the most important is the follicular, then there is a papillary, right? These are the very important one. Then there is anaplastic, there is a medullary, and there is a lymphoma. Okay, these are the primary one. This incidence, you can see thyroid cancer 3.7%, more in female. Thyroid is the only endocrine gland where in malignant tumor is spread by all possible routes: local, lymphatic, blood, right? And you can see it's a MCQ: papillary through the lymphatics, basically, follicular through the blood, and anaplastic, lymphatics and blood both. Remember this. Papillary carcinoma, 70 to 80% common in females in younger age group, maybe at 16 years of age. Slowly progressive, less aggressive tumor, commonly multicentric. So we have to remove the whole gland, right? Follicular carcinoma, thyroid, 10 to 15% of cases, common in female. It is non-invasive, blood spread not common, and one type is invasive blood spread common. Typical feature is that which you have to remember. Difference between a follicular adenoma and follicular carcinoma is that involvement of the capsule. Carcinoma involve the capsule, right? Invasion of the capsule and angio invasion. Okay. So if you just do the FNAC, final aspiration cytology, you will pass your needle will pass through the capsule and go into the thyroid substance. And when you come out, you don't know whether it is a carcinoma or not, because there is no report about the capsule. So we have to, in this case, external biopsy, we have to remove the piece along with the capsule to see whether it is involved or not. If it is involved, it is a carcinoma. If not involved, it is a adenoma. Spread, I told you that is a more aggressive tumor, spread through mainly through blood into bones, lungs, liver. And bone secondary are typically vascular, warm, pulsatile, localized in skull, long bones. Medullary carcinoma, very important. This is a soft tumor, very soft tumor. Okay? Arise from the parafollicular C cells. They will ask you from where it arises. Parafollicular C cells, which are derived from the ultimobranchial bodies, neural crust, and not from the thyroid follicles. This is important. Contain calcium amyloid stroma. In these patients, blood levels of the calcitonin stimulation is high. Is a very useful tumor marker. So if the calcitonin increase, that means it is a medullary and is soft, and there is a diarrhea. These three things are very important in medullary carcinoma: diarrhea, calcitonin level high, and then that is a very soft tumor. And this is also associated with different other organs in MEN 2A and 2B, right? This is very important. This MEN is multiple endocrine neoplasia. There are different endocrine glands they are involved, so you have to look into this. At this level, you don't need to know this, but you should know that this is associated. Clinical features, I told you, diarrhea. There is it's soft, and it might be involved because of other endocrine gland, pheochromocytoma, hypertension. This might be there. Anaplastic carcinoma, it is undifferentiated, very aggressive carcinoma, usually in elderly females, or tumor of short duration, present with swelling in the thyroid region, rapidly progressing, causing stridor and hoarseness of voice, dysphagia, fixity to the skin. Swelling is hard with involvement of isthmus and lateral lobes. Then there is a malignant lymphoma, right? It is NHL type, occurs in a pre-existing Hashimoto's thyroiditis. They might ask you in which thyroiditis there is the involvement of lymphoma, or which lymphoma is associated with which kind of thyroid inflammation. So autoimmune disease which is associated with lymphoma is the Hashimoto's thyroiditis. FNAC is useful to diagnose. Thank you.